Good morning from New York, and welcome to the live webcast of peripheral and endovascular cases from Mount Sinai Medical Center Cardiovascular Catheterization Laboratories. Just before we get connected and as we're getting ready in the cath lab itself, let me remind you the program for the next transmission will be in exactly 1 month on March 26th, Wednesday. Same time. During this program, you could be sending us any questions at the email info@peripheраlinterventions.org. And as usual, through the website, the archives button, you will be able to see this website just a couple of hours after its completion, in case you missed some parts of it, as well as any previous websites, including the blog of questions and answers that we always do regarding comments you send during the case and after the case, which we answer them comprehensively. A couple of more reminders that in addition to peripheral endovascular cases, we have also a live webcast of coronary cases. On Tuesday, March 17 will be the next one. The same time as today, whenever you are around the globe, and 8 a.m. Eastern Standard Time in the United States. And in addition to that, we have a live webcast of controversies in clinical cardiology, and the next one is going to be live with Dr. Fuster and faculty in the afternoon of March 16 at 5:15 p.m. Eastern Standard Time, New York, and you could calculate the time difference wherever you are around the globe. I think enough of housekeeping. Welcome to today's webcast from me, George Dengas, Cardiovascular Catheterization Laboratories, Mount Sinai Hospital. And let's go to the live case. Dr. PK and Dr. Wiley are joining us.
Thank you, George. And I'd like to welcome all of you. It's been a very cold winter here in New York, and we've had some tough cases the last 2 months, and this year, and this is no different. But I'd like to introduce our team as always, and our guests today. We have Ray Lascano, our interventional nurse practitioner, Surbi, our interventional fellow, Dr. Jose Wiley, who's here with us for every case, and then we have Dr. Karthik Guja, who's our endovascular fellow, Elizabeth, our nurse, Ricky, our tech, and most importantly, our guest speaker today is Assistant Professor of Surgery, Dr. Jose De Leon, who's the podiatrist, limb salvage specialist at Montefiore Medical Center, who's kind enough to join us. And kind of, the object of this has always been to really try to get a multidisciplinary approach. As those of you who've seen these cases know, we always have different specialties collaborating together, and we're thrilled. Jose, welcome. Thank you so much for coming out early.
Thank you.
So without further ado, I'm just going to ask Dr. Guja to present the case, and we're going to get started.
Good morning, everyone. Can I please have the slides on? All right. So we have a 66-year-old male patient with complaints of left foot pain at rest and a non-healing wound on the dorsal surface of the left first and the second toe. So he's basically a Rutherford class 3 category 5 on the classification with minor tissue loss. He has a past medical history of hypertension, dyslipidemia, diabetes type 2. He's on metformin, aspirin, clopidogrel, amlodipine, lisinopril, simvastatin, and he's an ex-smoker. Next slide, please. Next slide, please. So his vitals were pretty stable, and on physical exam, basically his pulses are Doppler PT bilaterally, and he has a non-healing wound on the dorsal surface, as I mentioned, the left first and the second toe with mild erythema. We have performed a prior angiogram before, which showed a non-obstructive disease of the right SFA with significant stenosis of the distal right anterior tibial and PT, and a non-obstructive disease of the left SFA, which we are going to show now, with significant stenosis of the left posterior tibial and a CTO of the anterior tibial, which reconstitutes via the peroneal artery collaterals distally. So basically the case plan today is for the endovascular intervention of the long segment calcified anterior tibial CTO.
Thank you so much, Karthik. So George, I just want to go over the angiogram and get started.
Yeah, that'll be very important.
And since we have Dr. De Leon, we really have an expert here on wound care to really help us in trying to discern what's going on. So you can see here in this particular patient, the first and foremost, nothing changes. We want to make sure you have an iliac shot. We had that earlier. There's no inflow disease. I'll show you the SFA shot. There's no SFA disease. There's no popliteal disease. Below knee, you can see you have an anterior tibial, you have a peroneal, you have posterior tibial in the first picture, and in the second picture, which probably shows better than this one, you'll see that the anterior tibial, the peroneal comes down as a dominant vessel, collateralizes through the communicating branch to the anterior tibial. The anterior tibial runs into the foot as a dorsalis pedis, and now I also want everybody look at that posterior tibial artery. That posterior tibial artery is also severely diseased. So this gentleman does not have a functional arch. So he does not have any collateral circulation going on, and that's part of the reason why he's had this issue with this chronic non-healing issue that he's having with his first and second toe. So second you want to see here, we just took a shot of the SFA to show what this is, and I want to take this opportunity to really talk about two concepts. First and foremost, the distribution of the vessels based on the arterial distribution. For instance, the classic teaching that the anterior tibial artery dorsalis pedis is the dorsum of the foot, and the posterior tibial is the posterior aspect of the plantar surface of the foot. And we're going to spend a little time talking about the angiosome-guided concept, which I know has caught on, and I know George, yourself, myself, we always talk about it, to really figure out what's the right way, and then use Jose's expertise to talk about what he is seeking in terms of blood supply, because this patient is going to need some help in terms of healing this wound. So interventionally, can I have my fielder and my fine cross, please? So interventionally, let's talk about a few techniques. So first and foremost, I know in our own lab, George, you know very well, Dr. Wiley uses his guide. He likes to put a guide at the level of the popliteal artery and inject, and I'm going to give him an opportunity to talk about that. And you and I generally come from above. If I'm wrong, please let me know. So I was just wondering whether, Jose, can you talk a little bit about your approach to these kind of disease? Where's my fielder, guys?
This is your fine cross.
Jose.
Yeah, sure.
Go ahead, Jose.
Yeah, so when I'm dealing with infrapopliteal disease, particularly proximal tibial disease, in patients who have renal insufficiency or I do not want to use much dye, I usually bring down a multi-purpose catheter, park it at the level of the popliteal artery, put from the back I inject dye, and I do my intervention through that multi-purpose guide catheter.
So basically, Jose, why don't you talk about the setup for the people at home? So what you do is you have a 7 or 6 French sheath. What do you normally use?
Yeah, I usually use a 7 French sheath. There's no reason why you cannot use a 6 French. But I then advance through that sheath, through that crossover sheath, a 6 French multi-purpose guide, and I park it at the level of the popliteal artery.
Ricky.
I put a TUI in the back, and I will advance my wires and inject dye through that multi-purpose catheter. The only drawback from this technique is that if the patient is tall or the lesion is very distal, when you're going to put your balloons in your stent, you probably run out of space, and then you got to take it out. But if it's proximal to disease, it works quite well.
So that's a great technique, George. What do you use, George, on your approaches on these kind of difficult distal lesions?
Well, I think that it's very important to clarify that in the infrapopliteal territory, you really need high fidelity angiographic pictures in order to navigate. And clearly, if you are injecting 3 bifurcations higher from the iliofemoral area, you just send a lot of dye elsewhere, and you just have both low fidelity pictures that are more prone to patient movement, because also you need to have a lot of time delay, and third, you just have more dye. So particularly in a case like this one, that essentially you're free of disease proximally until the popliteal, and it would be very safe to take the guy down and inject selectively. I think this can be a no-brainer, I would say, to use a similar technique like that. The only difficulty comes up if it's not so smooth to go down there, and you know, taking a guide over a wire over a long segment that may be somewhat tortuous and with some disease, you may introduce some dissections in the superficial femoral or the popliteal. That might not be a good case.
I think that's a great point that Dr. Badangas makes. Is the technique that Dr. Wiley is discussing is something where you can really do it when you can actually deep throat either your sheath or your diagnostic your guide catheter, coronary guide catheter, all the way level to the pop. Very important to make sure that there's no dissections. But I also want to talk about one thing. You have a lot of anatomic things that you can look at. Now look at this patient. Look at the roadmap by calcium that we're getting without even injecting dye.
Incredible.
Right? So that's something that I want all of the interventionalists out there to realize, that a lot of times you do not need to have too much dye, especially in these cases. You have a lot of anatomic landmarks that you can really use to be able to do this. So if you go back angiographically, you know, when you look at your DSA shot, you could almost see pre-DSA that there's a little bit of calcification that you'll be able to see before it turns. Actually, this is a poor timing, but you can almost see that you'll have calcification. You can actually see it more in the SFA picture, where before you inject, you actually see that you have that calcification. See it right there, the calcific shadow. You see it right there.
Yeah.
So that gives you a hint that, you know what, hey, I may not need to use as much dye. So as far as our interventional technique here, what we decided to do is we decided to go with a fielder and a fine cross catheter. The fielder is a hydrophilic wire, and we tend to use it, George, as you know, in a lot of coronary CTOs as well as in our peripherals as sort of a starting wire in order to get down there. I mean, obviously, it's very, very torqueable, and one of the difficulties that people have when they go up and over versus antegrade is the torqueability. So let me speak a little bit about when we choose to go up and over and when we choose to go antegrade. We are about a 90% up and over lab. I mean, there are times, obviously, where we do go antegrade, but clearly most of the time we go up and over. And so torqueability sometimes become an issue if the iliac is very tortuous, as well as your proximal inflow vessels are very tortuous. So we find using a support catheter, such as the fine cross, or the Corsair catheter. These are trade names because there's no other names I can really use. They're a support catheter that are very, very fine, that allows us to get really, really close to the wire and allows a lot of crossability of these particular catheters across the lesion. Now, obviously, when you look at this lesion, and I want you to look on the anterior tibial artery between 20 and I guess 30, right around there, which is the anterior tibial, which is right in the middle of your screen. You have a segment that's underfilled. Now, I want all the interventionalists out there to understand that there's two things that can be happening here. First and foremost, you may have a significant stenosis with overlying thrombus that's causing this slow flow. So this may not be completely occluded, and I would not be surprised if this is not completely occluded. Second, the more logical, the more obvious thing from angiographically, you may say to yourself, hey, this is completely occluded, so you know, I'm gonna have to use more different techniques. So my algorithm has very, very clearly been in these kind of lesions, go with the hydrophilic wire. Do it under high magnification to see how the wire behaves. If the wire behaves where it's circling up, you're not able to get any pushability or penetrability into that occlusion, then you probably are dealing with a chronic total occlusion and you have to go through some chronic total occlusion wires. If that's not the case, then we just go with the most minimal wire that we need. And as you know, in the coronaries, the field is very, very good, and when we're able to get through. I'd be curious to see what your thoughts are and what Dr. Wiley's thoughts are.
Go ahead, Jose.
Yeah, I agree with Prakash. I think what is critical here is how the wire behaves. If it flies down with no resistance, you're probably dealing with thrombus, in which case the approach will change from a CTO approach. If you have some resistance with your wire going down, then you're obviously going to be using CTO wires and the same techniques that we use in the coronaries.
Yourself, George?
Yeah, even the guide technique is going to bring the whole thing much closer to the coronary. Let me get back to the need for a high fidelity angiogram. in order to understand and define exactly where the trickiest parts of the vessels are and all that. So it's not only the dye that one saves by highly selective injections, but it's also that you gain a high fidelity angiogram regarding where your critical manipulations are going to be and how they are going to be. And let me also make another point that if someone is not interested in using a guide, a good alternative technique might be, if the femoral bifurcation is free of disease, you put your sheath all the way in the proximal SFA, so at least you bypass the profunda bifurcation and you don't inject in the profundum.
Now, George, you saw the two things right there, how the wire behaved, and I want everybody to see the wire right there, how it looks. So when you see the wire right there, how it looks, what that shows is the wire is meeting resistance. And to me, this is the most critical aspect of these particular cases. What happens here is, if you get subintimal at this level, it makes your life more miserable. So the key here is, this is where I give a little extra dye, even in patients with renal insufficiency, to really kind of get a feel for where I'm going.
Yep.
So I'm going to inject a little bit, and I guess this is where yours and Jose's technique regarding where you place the catheter will limit the dye. What this does is it'll allow me to see where the reconstitution is. Obviously, that was all saline.
Yeah, let's see how we're going to see that. Yeah.
Yep. So I'm going to inject here. Oh, sorry, got an air column here. So with these, you can purge. Okay, ready? Let me just make sure.
As you can see, we're already in the distal third of the calf. So we're pretty distal from the injection point.
So you can see here, there it comes, and there we are. So we're actually quite close to that communication. You can see the communicating artery from the peroneal coming into the dorsalis pedis, and you can see the severely diseased and occluded posterior tibial artery.
I think the hydrophilic wire has taken us a very good ways, and we're aiming very appropriately.
Yeah, so
let's see if we can make the connection.
Yeah, so what I'm just trying to do here, George, is kind of see how my catheter is backing up. See, that's telling me a lot. Now watch my support catheter starts to back up. So that clearly is probably the occluded segment right at this area.
It's good to have resistance. This means you're in true lumen.
We are, exactly. That's an excellent point you just made. So what I'm going to do is just track this down a little bit slower, right? Get close, and you can see Ray Lascano has actually gotten closer to me. We worked together so many years that he knows exactly what the next step is going to be. And you can see here just a little bit of manipulation, very gentle, and hopefully we're not in the right spot. So now I'm going to switch out to the confianza, which is a stiffer wire.
And we have different types of confianza. Which one you want to use? The Pro 12?
We use the Pro 12. And that's a great point. Let's spend a little moment here on escalation of wire technique here. So as you know, George, and you could probably speak about this much more than me or Jose can, is about the escalation of wire techniques in the coronaries. And two things here is that what we normally do is we do not start, honestly, in below the knee with anything less than a Pro 12 wire here. After this, we escalated up into the 30 gram, the 25 gram, the 20 gram tip wires that are available from different companies. We do not believe that anything less than a confianza is going to work very well other than a hydrophilic wire below the knee. I'm talking about 014 wires. If you choose 018 wires, obviously that's again escalating beyond. So we use an escalating technique where we start with 014 wires, hydrophilic first to get where we are, and then start escalating the wire above that, and then going to the 30 gram, the 25 gram tip, and then going up to the 018 system. That's our algorithm.
I think this is a very reasonable one, particularly in a case like this one. You can picture that the last segment, the most distal segment of the occlusion, is rather straight. So essentially, you want to pierce through the distal cap. You know what distance you have to transverse, and I think the Confianza Pro 12 gram, which is a more powerful there is right now. I think a 15 gram is coming up, but not here yet. Would be a very good one to try and see if we can give the final push.
PT Graphics.
Right. So we also have a hydrophilic wire, the PT Graphics family of wires, which are again very good wires as well. And and the key is really to.
I'm not so sure why you pulled it back though, PK. You kind of intentionally pulled back the the catheter,
I think you're right. I mean, I shouldn't have pulled it back. I guess the reason I did there was because I wasn't really comfortable with the way it was turning into that other area. So I worry with the fielder that we get into some dissection planes at times. And so what I would do is I usually redirect. See, like this wire is not behaving as, no, don't push it right. No.
There must be some like a long subtotal occlusion up there that somehow the hydrophilic help you transverse. That the confianza doesn't have these properties.
And you're right. I think you're right. You might have to go. There you go.
There you go. It takes it. But you can see, everyone can see the difference on how a hydrophilic wire behaves. I think maybe you should get the support catheter right next to it.
That's exactly what Ray's going to do. Go Ray.
Everyone can see that how the hydrophilic wire kind of flew through this subtotally occluded segment before, and how the non-hydrophilic tip wire is getting hung up a little bit. We've lost a little bit our alignment. I don't know if we can.
I think we crossed here, George.
Let's
see that? I think we're definitely through.
I think we're through. I would probably repeat the picture.
I'm going to go through with this right there and then check below. So George, I think that's a great point that you made. Me pulling back, I guess, I've done enough of these where I kind of felt that I was getting a little bit subintimal, but I think it's a good point for the folks at home that you made, because I think that is something that clearly, you should not do. Come forward.
Air column.
It's okay. Oh, air column. That you should not do, especially if you believe you're in a good position. And George's point is phenomenal in that particular position. If you give it up, the next time you try to go there, what may happen is that you may actually get into a dissection plane. So be confident if you feel that, hey, I'm in the right spot, and then do it. Then you're gonna be okay. Do not keep pulling the air back, the catheter back, and then keep creating dissection planes. We're going to get more dye here. Liz, can you make me some knife?
So let's look a little bit about the logistics of the distal injection. What size syringe do you use? And are you going to use 100% dye or 50-50?
I think here, George, the two things I want to really look at very carefully, and you notice I asked for vasodilators from Elizabeth, to really look at what's happening with the distal vessel before we even put a wire in there. So what we're going to do is we may even come a little AP here, and then we're going to shut her in and then go to DSA. And I'm going to try to see the arch as well as I can in order to see how we can help it. And then this is where I'm going to ask Jose for his expertise on what he looks at when you see this kind of thing. So let's inject here first. Excuse me.
You want to back up a little bit?
Exactly.
It's magnified.
You read my mind, my friend.
Magnified, yeah.
There you go.
All right.
Now we get a contralateral shot.
All right, we're 100% selective now.
Right.
That's great.
So now I want to show Jose the area of concern, which is between the first and the second toe, and see whether what he's looking at when he's intra-op in these in these particular patients. Jose, let me show you the angiogram first. So you see that ulcer right there? The area of hyperemia is not showing up well because I couldn't get a good head. But you can also notice the poor formation of the arch. So Jose, I'm going to turn it over to you here on what you think you would do, and what are the things you look for intra-op when you're trying to debride these wounds.
Well, the most important thing is to try to get this patient screened early on, before the onset of critical limb ischemia and before the onset of gangrene. I mean, once you get to gangrene, unfortunately, something will be lost in the foot. It's very important depending on where you have the gangrene. For example, if you're dealing with a first ray or a second ray, first toe and the metatarsal, you definitely want very good perfusion of the anterior tibial, which you're going to need, as well as the posterior tibial. Because in most cases, you will be creating some kind of a flap.
Right. So Jose, now tell me the importance of the arch. You see that this guy has a very poorly developed arch, right? So if he has a plantar arch or a dorsal arch, or we're talking basic about the plantar arch here, if he had a robust posterior tibial, would that be enough to heal a wound in this area, or would you feel that you wanted as much the blood supply as possible before you did a flap or whatever it is that you needed to do?
Well, it all depends on the extent of the gangrene and the extent of the amputation that needs to be done. If a large flap needs to be created and you have to do your flap dorsally, you may need a little more than just the posterior tibial.
Now, do you know that going in, or is that something you see only intra-op? Because a lot of times, the interventionalists out there who are watching, the surgical guys definitely know a lot more than the coronary guys in terms of what you need for blood supply. But, we use multiple different techniques that Dr. Guja is going to talk about now while I work. So is there anything that we can use clue-wise? I mean, do you feel that, hey, having as much blood supply is important, or if you can get, the territory that's involved open is enough? I mean, that's the kind of advice we're looking for.
Well, the most blood supply will be the best.
Okay.
Oftentimes, you go in thinking that you're going to do a simple amputation, but you may end up with extensive necrosis, either plantarly or dorsally, in which the amputation now is going to be more complicated. You may have to create different kinds of flaps. You may have to rotate different types of skin in the foot for coverage. And that will require the most amount of perfusion to the foot.
Okay, okay, then at this stage, Jose, normally when these patients come to us, they have these occluded vessels, right? I mean, you see these occluded anterior tibial, posterior tibial, whatever it may be. We tend to open one because of the issue with creatinine and other things, and then we bring them back. So is that something where we should discuss with the caregiver, the surgeon, whether it's a podiatrist, a vascular surgeon, whoever it may be, to say, hey, listen, this is what I've done? And is that where we need to get more collaborative in terms of, whether that's enough to heal this wound?
I think the collaboration can be improved because, again, in some of the cases, if you open up one vessel, it may be enough, but in a lot of the cases, it is not enough. It really depends on the extent of the foot surgery that the patient will undergo.
PK, what wire are you using down there?
That's a great point, George. What we do is, once we cross the lesion, we switch the wire out to a stiff support wire. This is a stiff support wire, which is made by one of the companies, and it could be any one, and it could be either the Grand Slam, the Mailman, any particular wire that you want, as long as it's a good support wire. Obviously, the thing I want to talk to before we start is how would you tackle the lesion, George? And thank you, Jose, for those great thoughts. But the point is, George, now you got this open, you're dealing with a guy with critical limb ischemia. You use the wire technique to get through. We've talked about different crossing techniques, using devices in the past. So now we should demonstrate a wire technique. Now, what are you going to do to treat this lesion? I want to leave it to you and Dr. Wiley, and then decide.
Well, I mean, certainly the characteristics of this vessel is that there is an occlusion in the distal third of the vessel, successfully canalized with a 014 system. However, the entire vessel has a rather diffuse atherosclerosis of, I would say, severe nature for at least half the length of the vessel.
Right.
Considering the possibility of either a diffuse low-grade ballooning throughout the entire vessel, or you may consider running some kind of calcium atherectomy device there.
That's a great point. Jose, yourself?
Yeah, well, I agree as well. I think nobody has the right answer. There's multiple approaches. It's very calcified. So certainly you could consider directional atherectomy or orbital atherectomy or rotational atherectomy. I don't think you can go wrong with either approach. But you could also do a prolonged balloon inflation and tackle that CTO.
I think that's all great points. I think two things. I want everybody to look at the angiogram. When you look at the angiogram, what George's point really strikes out at me, which is that you have a diffuse disease. That you have proximal disease, you have mid disease, two areas of mid, and a distal occlusion. So if you're going to do balloon angioplasty, obviously there's going to be multiple levels of balloon. Obviously the issues with balloon is possible dissection, but clearly has been the standard of care for a long time. Clearly we know works. Clearly we know also heals wounds. But we also know that in this type of diffuse SFA, tibial, as Dr. Dangus was saying, I think clearly there is a role for some sort of plaque modification. I mean, directional or rotational. And I think how I want to really get the point across is to look at what are the complications that may occur while you're using these devices. So first and foremost, okay, if you talk about a rotational type device, the rotational atherectomy devices, either the Diamondback device or the Jetstream device, they both may embolize distally, okay? The embolization distally can be prevented with the use of a filter in most calcific lesions, but however, in this particular area, a filter is not something that's going to fit. In my perspective, I think about it this way. If I embolize distally and close up that only open dorsalis pedis artery, then I'm in real trouble. I'm going to give Dr. DeLeon more trouble in terms of healing this wound. So what I think about how we can prevent that is to do shorter runs. When you do either a Diamondback device or a pathway device, if you choose that in this particular case, which are both very reasonable, you just have to do a very short pass. Then use copious amounts of vasodilators. When you use copious amounts of vasodilators, again, that also helps to wash out the debris and thereby preventing the distal vessel plugging. Now, directional atherectomy, which I've chosen, I'm very comfortable with directional atherectomy. I think that is not the only thing to do. There's plenty of things that you can do in this. I think allows you to be able to pass through and actually make one cut and then be able to do a prolonged balloon inflation without dissecting. I think that's true with all the different atherectomy devices. Lastly, George, I want to talk a little bit about drug-eluting technology. I mean, we know that drug-eluting stents are available in Europe for below the knee. We know that drug-eluting balloons are already available. We know that the Medtronic drug-eluting below knee trial was stopped prematurely for issues in terms of, as you know, so the question becomes is, what do you think about the future of drug-eluting balloons below the knee, George?
I mean, it's very clear that this diffuse disease, you got to do something more than just treat the short segment of occlusion between 25 and 30 marker down there in the distal tibial vessel. What to do, it's not so clear. One can say that perhaps the diffuse atheroma you debulk with maybe some orbital atherectomy or something like that throughout the length of this. And then you follow with spot stenting in a couple of areas, and perhaps you use a short drug-eluting stent. Other aspects would be like, you use a taper balloon followed by a drug-eluting balloon, which is a diffuse treatment with paclitaxel essentially. And that the last characteristic of the drug-eluting balloon is what I want to stay with. All drug-eluting balloons right now are essentially paclitaxel balloon. And no drug-eluting stent in the coronary, at least, is paclitaxel. And in fact, paclitaxel stent has shown to be inferior than others. So, are the current drug-eluting balloon limited by the fact that the industry can only load paclitaxel at the balloons right now? And would new balloons, perhaps with nanotechnology, would be able to really trap and elute sirolimus, everolimus, and so forth types of drugs that have been proven better targeted to the vascular stenosis, at least in the coronary, and translate that experience to the periphery, and hopefully produce better and superior results with drug-eluting balloon. So that is clearly a limitation of the current DEB, so to speak, because all of them are PEB, paclitaxel eluting balloon, and we're not so sure that this is really what's happening. PK chose a different type of atherectomy here, which is the more the directional atherectomy. Tell us a little bit about the type of device you're using here.
Now, George, I chose the EXL device. The EXL device is a longer nose tip, and you saw how I did it. What we try to teach everyone is you want to be able to pass the device through the lesion. I want the camera to show us here. I want the camera to show us the access site. When you see the access site, you see how close we are. This is not a short gentleman, and you can see how close this device is to the end. So what I did was we actually have tubed the sheath as far as we can to the SFA, or close to the SFA, and that allowed us enough length to get down there with the device. We only have a little bit of play to work with, and you'll see. So we use our markers, our marker catheter here, which is the tape, the glow tape, to actually see we need to go from 20 to 25, and you see how I pushed it all the way down to actually make sure that I'm not going to stall or grind in any particular area. So when you stall or grind in any particular area, it's sort of like the similar technique that we talked about with Diamondback and Pathway. What happens is when you go ahead and stall or grind in any particular area with this particular device, the directional atherectomy device, you can perforate. So it's important to make sure that it's able to fly through in a very, very manner. In this particular case, because of the diffusely diseased nature of the vessel, I'm only going to make one pass. Normally we make about 2 passes in this. We'll make a pass and then we'll take a picture and then we'll decide. If there is a chance we can perforate. If we perforate, we're ready to deal with it with whatever needs to be done. So I think these are the things that you need to see. And now we're going to go ahead and get ready. We're going to start. Now I want you to look at the characteristics of the catheter. I don't want you to bias this catheter in any way. So I'm going to make an anterior posterior cut right there on. So I'm just going to come very, very slowly. Okay? As you can see, I'm just coming very slowly. I have a large nose cone here that's going to allow me to collect all the debris. Now people will say to you, oh, in calcific lesions, this doesn't work as well. Well, we don't know that. You know, I really think that this particular device works pretty well in all the different areas, especially since it has an aggressive cutter. Okay? A little bit lower. Okay? Going to keep coming down, you know, all the way down to about 28. And there it goes right in now. Now you can see, now I want you to see where I'm hubbed here. Show my hand. Now you see how close we are here, guys?
Yeah, if we were using a guide, we would have to take the guide out over the wire and advance this. Anyhow, this would not fit through the guide, so you would have to do it even for size. DSA, but also you got to do it for length.
The DSA? So we made one pass. Now, you know, like I said, you know, you have to inject. So you have to be ready for anything. We have our balloon ready. It's not that we're expecting anything bad to happen. Now look at that. With one pass, we've been able to do it. And I think that's what I want to really get across to everybody. You know, you don't need to make 10 passes to decide that, hey, you know what, I'm finally going to go ahead and take a picture. You're in an extremely small vessel. We talked about all the things that are going on in this vessel, George, all 3 of us and Dr. DeLeon. So therefore, we really know that one pass may be all that's needed. This is a very large device with a very aggressive cutter. So I went ahead with one particular pass, nice and slow, using good technique, took a picture. I'm happy now. I'm very happy. Now what I'm going to do is treat the stenosis proximal, and then I'm going to do a prolonged balloon, and I'm out of here. You know, so while I do that, I'm going to have Dr. Guja talk a little bit about angiosomes, and then I'm going to come back to Dr. DeLeon to give his thoughts as well. So Karthik, can you scrub out and talk a little bit about angiosomes? Do you need to scrub out, or?
I don't think.
Oh, actually, can you put up the slides? Dr. Guja can just talk from here.
Slides on, please.
Slides on? You can take me off this
Yeah,
one.
we're good.
There you go.
Go ahead.
Okay, so I guess because of the nature of the ulcer and the intervention we are doing below the knee, I think there are 2 concepts. I mean, some people believe in angiosome theory, some people don't. I think they have been. I'm going to show some trials which have looked at both angiosome versus non-angiosome. So let me talk about angiosome, because we believe in Sinai that angiosome theory does work, and it's important to attain a straight line direct revascularization of that vessel to that area of wound. So there are 6 angiosomes in the foot and ankle, originate from the 3 arteries. The first, let's talk about the plantar surface. The posterior tibial artery gives 3 branches. One is the lateral plantar artery, which supplies about 2.5 of the plantar arch. And then medial plantar artery, which supplies again 2.5 to 2 of the plantar area. And then the calcaneal branch of the posterior tibial artery, which is the third branch, supplies about half of the plantar area of the calcaneal area. And then the peroneal artery has 2 branches. One is the calcaneal branch, which goes to the rest of the half, which is the lateral surface of the calcaneal area, the plantar surface. The other one is the anterior branch, which supplies about the lateral part of the plantar arch, about you can say about 1 to 1.5. Now the anterior tibial artery, which takes a lot of surface along, just like the posterior tibial artery, takes the dorsum of the dorsum of the foot. Almost pretty much the whole dorsum of the foot is supplied by the anterior tibial artery, which comes down as a dorsalis pedis. So next slide, please. So now the strategy for below knee angioplasty based on angiosome concept. The two papers which came up early on and which was published, which looked at the first paper looked at angioplasty just with balloon angioplasty, which took angiosome theory as appropriate, and 83% of the wounds healed, and the boundary lesions where the angiosome looked treated looked at 59 healed patients. Now, when we looked at bypass, again, we can go back to basal trial and look at this, but the bypass again looked at it, and then angiosome treated patients had 91% healed. So now bypass versus PTA, we can talk about at the end of the presentation. Next slide, please. So there's a recent article which came up in Journal of Vascular Surgery in 2013, which looked at angiosome-treated infrapopliteal lesions in diabetic foot ulcers. Diabetes plays a major role in angiosome theory. Non-diabetic patients, again, there's a questionable ideas about using angiosome in non-diabetic patients. I can talk about why. This paper looked at 250 limbs, of which there are 226 patients. Now, direct revascularization, which we're talking about, the straight line flow, as we always talk about, when looking at 6 and 12 months, they had 72% healing of the diabetic foot ulcers at 12 months. When we talk about indirect revascularization, that's non-angiosome, that we're talking about doing a posterior tibial artery to give an anterior tibial artery wound supply through the plantar arch. Looked at only 46% healing rates at 12 months. Now, clearly, the p-value is pretty significant for this study, which looked at direct revascularization group has a faster ulcer healing rates, especially when podiatric surgery, as Dr. DeLeon was talking about, needs a more straight line flow. The next slide, please. Now, the outcomes of the angiosome and the non-angiosome targeted revascularization in a critical limb. Now, this study looked at 64 patients, and again looked at all kinds of lesions, forefoot and heel lesions. This study showed no difference in limb salvage. I'm showing this study because there are people out there who don't believe in angiosome. They think the patent pedal arch is enough for any wound in the leg to be healed. Next slide, please. So what is the problem with angiosome theory? Where does angiosome theory lack its importance, especially in non-diabetic patients when they don't have calcifications, and when they have rest pain, no tissue loss? Angiosome theory again has no importance. Clearly, we all know that wrist claudication, foot claudication, below knee treatment is not for foot claudication. Lesion above the ankle, again, angiosome theory fails because, again, there's a lot of borderline supply, a lot of collateral supply, especially from the peroneal artery. And superficial ulceration, which can be healed by any plantar arch supply. When the toe pressures on the ABI, which is, again, it's important to look at ABIs in these kind of patients, because if the toe pressures are more than 50 after the angioplasty, again, this angiosome theory has no importance, because with the amount of toe pressure more than 50, even the pedal arch can heal any wound. So again, fully intact pedal arch again is a questionable question against angiosome theory. The next slide, please. So the limitations of angiosome theory are the variability in angiosome coverage. Sometimes the peroneal artery is so dominant, it covers the posterior tibial branches. Sometimes the anterior tibial is so dominant, it takes over the peroneal artery supply. So it's difficult to say which artery will actually heal that particular vessel. As Dr. Krishnan was just showing, you have to take a magnified view of the plantar surface to see exactly which vessel is going down to that ulcerated area. Then probably it will be a better idea to make a decision on to intervene or not to intervene. Again, the difference in collateralization, sometimes the peroneal artery, especially the source of significant collaterals, gives a lot of supply to other vessels. Again, the revascularization of boundary angiosome, especially on the plantar surface, where the PT and the peroneal have a lot of overlap. If the ulcer is present on those boundary angiosomes, the question is what to do with these angiosomes. The next slide, please.
That's the last slide.
Okay. So
we have a question regarding the angiosome approach and its relation or not with the post-revascularization ABI. How does the angiosome distribution relate to the improvement in the pressure as detected distally.
Again, as I said, once you do toe ABIs, unless the ulcer is right on the toe, when you do toe ABIs, if the toe pressures are more than 50, you've achieved what you want to be. Right? That's the goal.
You know, just to build on that, George, I think the best way to answer that I could think of is if you do TCPO2. If you do angiosome-directed revascularization at the level of the ulcer, and that ulcer has a TCPO2 greater than 50, the chances of that ulcer healing are extremely high. And I'm going to let Jose talk about that, because I think that when I trained, we used to do TCPO2 on all these ulcers, and that's what we did. We don't do it here, but I think that's the concept. I know that Dr. Graziani was going to be at our conference in June in his diabetic foot clinic with the podiatrist in Italy. They do TCPO2 on all these ulcers and achieve a TCPO2 greater than 50. So I think if you look at the post-procedure TBI or ABI as a marker of improvement in flow, that may be true, but it's not necessarily going to be improvement in flow in the area that you need the blood that Dr. De Leon was talking about. Because in this particular area, you need blood in this particular region to really heal the incision that he's going to make, the flap that he's going to make, whatever else that he does while he's in there. So my opinion would be to do a TCPO2 if you want to be completely certain. Jose, any thoughts on that?
I think it's important, but we can't forget the type of ulcers that we're dealing with.
Great.
And the type of procedures that are going to be performed on this patient. If you're dealing with a relatively simple wound, after revascularization, the patient should heal. And perhaps people can say, well, angiosomes don't play such a big role. But if you're dealing with a complicated wound, a patient that will need extensive reconstructive foot surgery to heal that wound and to preserve the limb, then angiosomes do become significant.
So I think George, the presentation that Dr. Guja made is extremely informative for our audience. I'll tell you why, because I think, there's a lot of excitement among the interventional community. I was recently at one of the major conferences, and one of the things that they really talked about a lot was this angiosome concept. And exactly as Dr. Guja talked about, and I'm going to ask Dr. Wiley his opinion, there's actually two different communities. There's one community that says, hey, you know what, as long as I got a plantar arch, I'm happy, I achieved my goal. The other community says, no, I want to have flow to the ulcer area, and I'm going to use angiosome guided. Now, having said that, the area that we just revascularized, which is the toe, the great toe has dual distribution angiosome supply. So you need both the posterior tibial and the dorsalis pedis to be able to get supply to that great toe. This one, as Dr. De Leon said, you need to know what you're treating. Here we know the guy has got gangrene. Here we know that this toe is likely going to come off. So therefore, what's going to happen is going to be a debridement and a healing of that particular side flap, whatever it is that we're going to do. So I think, if it does not, then we may have to go back and do angioplasty of that posterior tibial artery, which again, we're beyond the scope of our time here. But I think that's the approach that we use here. Jose, any thoughts on you with the angiosome versus the conventional?
Yeah, well, I think in 2014 we should be a little more sophisticated. So I think the use of the angiosome is very well accepted by the community. I certainly use it, and I advocate that people out there consider its use as well.
Okay. Jose, any thoughts in terms of, we're going to take a final shot here. Any thoughts that you can add to us as interventionalists on what are the things that we need to go down, please?
Now, is this a taper balloon that you're using or not?
This is a taper balloon, George. We just ballooned the entire posterior, the dorsalis pedis after atherectomizing the spots that we wanted to. And we used a 2.5 by 3 millimeter tapered balloon. We believe that the distal vessel was clearly a 2.5. The proximal vessel was a 3. And so we cover the whole vessel with a tapered balloon, which I think is very unique in the endovascular space, that we do have these tapered balloons. So now we're going to take a look, and God willing that everything looks good, and we're pretty much done here.
You have some nitrite out there?
There's some nitrite, guys? So Jose, you talked about the different types of wounds, right? This is 1 cc, guys? Mm-hmm. Okay. So I want to tell everybody what we use for vasodilators. I mean, we're very conservative because we have a lot of elderly patients, aortic stenosis, left main disease, etc. We use nipride and verapamil, and we generally dilute 1 in 10. So basically 50 mics of nipride, which is 25 mics of nipride, or this is nipride? 25 mics of nipride in 10 cc's, or 9 cc's of saline. And then we go ahead and just shove it right in there. And again, this will work better if, like Dr. Dangus said, if it's more concentrated and delivered to the spot, which we would have done if we have a catheter down there. Right now, we don't have a catheter down there, so but this should be enough to see how it looks. So we just shove it down, and then we're going to take a nice shot. Mag up, Jose, and put me on DSA.
Yeah, but still, as you remember, PK had told us that he pushed the sheath into the proximal SFA, so he's essentially more selective than if the sheath was up in the iliac. And clearly a lot of dye and medication escape in the profunda circulation. If the sheath is in the SFA, then the drugs and the dye are distributed into the popliteal and infrapopliteal circulation quite selectively.
And there's your final vessel. That's a little collateral that you have down there. No dissection or anything that you see. It's a little collateral.
I think it looks great, and we could.
I'm going to show the foot for Dr.
Remove the
DeLeon.
wire to get a better picture.
Yeah.
Because it's a funny wire. It has like a too long of a radio pack tip.
Now you see the dominant flow is through the posterior, through the anterior tibial and dorsalis pedis, and look at the amount of blood supply that foot is getting now as compared to before. So I mean, I think that this is a great case really to show not so much the difficulties. I'm sure everybody can do these cases. It's to understand the concepts of what it is that we're trying to get across. First and foremost, I think, inject please.
Yeah, there's an air column here.
Oh, there's an air column. Sorry. First and foremost, the multidisciplinary approach. First, okay, please. Air column detected, guys. Can somebody help? So first and foremost is the multidisciplinary approach. We have Dr. DeLeon here. We work very closely with podiatry, and then are able to understand what it is that they need for us in terms of the blood supply that we can give them. And number two is to also work with the techniques that we talked about to do this safely. Purge, please. To do this very, very safely. And you can see that it doesn't really matter what device you use. It's really more, inject please. It's really more about the safety for the patient in order to be able to achieve a good result. Now, while we mess around with this hair column, I'm just going to ask Dr. DeLeon any final thoughts about what else that we could share with our colleagues out there.
Well, it's important that once the patient has been successfully revascularized, that the issue with the gangrenous toes be taken care of. I personally prefer to do it within 48 hours of successful revascularization, and I try to achieve 100% closure. It's important to get 100% closure on these type of patients because of the comorbid conditions, the multiple risk factors, and unfortunately, the restenosis that can possibly occur with these patients.
So I think that's important. I want to talk to you, Jose, about operating on an antiplatelet agent. These patients are on antiplatelet agents once we do these kind of revascularization. Is there anything in the podiatric field about operating? Is there an extent of surgery that the interventionalist needs to worry about? Anything like that in terms of stopping? Because we like to continue the oral antiplatelet agent at least for 30 days. In these kind of cases, maybe even longer. The data is lacking. It's become more of a what we feel is the right thing to do. So I think 30 days, most people would agree, would allow the dissections to heal, et cetera, et cetera. But as far as you operating on it, how do you feel about that, and what's the situation?
I really have no concerns about the antiplatelet agents that the patient is on. They may have a little excessive bleeding during the procedure, but that can easily be controlled. So that's not my concern. I do not stop the antiplatelet agents. I proceed with the surgical procedure. And again, the goal is to have complete closure of these patients.
So you can see here the proximal AT also looks very good. So I think we've achieved great flow into this. I'm going to do a summary outside after Dr. DeLeon gives his talk. He has an incredible talk on wound healing basics for the interventionalist, which I think is important for all of us who take care of these lesions. And I thank obviously Jose Wiley, Dr. DeLeon, thank you, Surabhi, thank you, Ricky, George, yourself, and obviously Ray and Karthik. George, before we sign off, we promised the audience that we would show them the last case that we did. Remember, we ran out of time. So I'm going to go outside. I'm going to show them the last case that we did while Dr. Wiley helps me here. So
All right, excellent. So let me take a moment. This was an excellent case, and let me remind everybody that the next endovascular case is webcast is going to be at the same time on March the 26th, on exactly 4 weeks. And before that, we're going to have the coronary live webcast on Tuesday, March 17th, at the same time again at 8 a.m. New York time. And also, one day before that, Monday, the 16th, we're going to have the clinical cardiology controversies live webcast with Dr. Fuster and faculty at 5:15 p.m. New York time. That's in the afternoon New York time. And obviously I know this is attended throughout the globe.
What frame number?
In many continents and many countries, so please calculate your respective times accordingly. I think I would close from my point of view. We've closed already from the cath lab. Thank you all for attending. If you want to have any questions, send it to us at info@peripheраlinterventions.org, where we're going to answer it at the blog that accompanies this case. And as you know, if you use the archives button of the webcast, of the website, you will be able to view any case we've ever done, along with a blog of Q&A, as well as today's case, which is going to be up in a couple of days, along with a blog of question and answers that accompany it. And let's go back now to PK to show us the final result of the last case, which has already been archived.
So George, as you know, we've got, I'm just showing you the first picture. You've got the in-stent restenosis of the SFA, right?
Let's look at the angiogram, please. Great.
Can you see it or no?
Yeah.
Okay, and then you saw below knee, you had the occluded popliteal with the dorsalis pedis, our anterior tibial coming down, TPT, and the posterior tibial. So when we left you, we were working on the popliteal, and I'm going to show you what we ended up doing. It took us obviously quite a long time, and maybe was not the ideal live case, but we really want to show you what are the things that can be done in these particular cases. So this is a classic example of global revascularization. So we got through the popliteal artery. You see here, we did atherectomy of the popliteal artery with good flow into the dorsalis pedis. You can see here we had to put a drug-eluting stent into the dorsalis pedis artery. When we put a drug-eluting stent into the dorsalis pedis artery, the reason is that was the only outflow for that particular patient with the ulcer. And you remember that lady had a horrible gangrene. Then we went ahead and re-ballooned the posterior tibial artery to open it, and the peroneal artery, so that you have the dorsalis pedis artery. I said dorsalis pedis. We re-ballooned the peroneal and stented the drug-eluting stent into the peroneal. We ballooned the anterior tibial artery here and the posterior tibial artery here. So we ended up as the end result to basically have a balloon of the atherectomy of the in-stent restenosis of the SFA, atherectomy of the popliteal, drug-eluting stent of the peroneal, and atherectomy and balloon of the anterior tibial artery, as well as prolonged balloon inflation of the peroneal artery. So you can see here in these type of patients with significant multi-level disease, you have to do multi-level angioplasty, atherectomy, and stent. Okay, we also had 3 vessel runoff into the foot, and the ulcer is doing quite well. We sent them to our podiatry colleagues, and now they're doing the important procedures for them in order to help heal the wound. The 3 things, the data regarding drug-eluting stents below the knee is very, very sketchy. In our ACC write-up that we do, which we'll also do following this case, we sit with Dr. Guja and I sat down with Dr. Wali, and we looked at the Yukon BTK, we looked at Destiny, we looked at all the trials in Europe that have been performed with that. We also have Dr. Robert Lookstein of Mount Sinai, who published our single center data regarding the sirolimus stent. So I think clearly that this type of intervention is extreme. This type of intervention is time consuming, costly, but however very beneficial to this patient. As you see, we were able to restore a 3 vessel runoff to the foot, straight line flow from an occluded SFA to an occluded popliteal all the way down into the infrapopliteal vessels, and this patient will heal and do very, very well and be left with a functioning foot. Again, as always, we want to give you guys follow-up, and we thank you. Thank you so much for logging on, and we'll see you guys in the next case, and we'll see you in June at our live symposium of endovascular and coronary cases.
That's great, PK. The symposium is on June 10. The last case PK show you, this is a type of case I would try to put on triple antiplatelet therapy, the aspirin, the clopidogrel, and the cilostazol, if the patient is able to tolerate it. Again, this would be the maximum antithrombotic, anti-restenotic oral regimen we have right now. So again, goodbye from the Mount Sinai Cardiovascular Catheterization Laboratories today, and we meet again on March the 26th, same time for the Peripheral Endovascular webcast.